The detailed neurological examination of the foot and ankle will be programmed on the physical examination of the lumbar spine and neurological examination of the lower extremities, but would normally be performed at this point in time. Vascular examination. Examination of the vascular status is an extremely important part of the physical examination of the foot and ankle. The foot and ankle are at the end of the line, so to speak, and vascular alterations both proximally and distally can have enormous effects on the foot and ankle region. The hair distribution and the appearance of skin texture over the lower leg are important aspects to note. The appearance of varicosities in the lower extremity, as well as stasis dermatitis or stasis ulcers, are also noted. With the patient lying in a relaxed position, the capillary filling can be assessed by squeezing the nail bed and recording the time for blanching to disappear. The pulses are then palpated and compared to the opposite extremity. The posterior tibial artery is located behind the medial malleolus between the tendons of the flexor digitorum longus and the flexor hallucis longus. This artery provides the main blood supply to the foot. It is most easily palpable when the accompanying tendons are relaxed, and thus the patient should be in the supine position with the whole lower extremity supported by the examining table. The anterior tibial artery, or dorsalis pedis artery, is located between the tendons of the extensor hallucis longus and the extensor digitorum longus. These tendons have been located previously during the examination. It is the dorsalis pedis artery that is most easily palpable about 2 inches below the ankle joint. If on the basis of the vascular examination insufficiency is suspected, the quality of the pulses should be reassessed after the patient has been exercised. Special tests. Ankle instability. Ankle sprains are a common everyday occurrence, both during athletic endeavors as well as occurring in general everyday activities. Inversion injuries are more common, hence injuries to the lateral ligament complex are seen more frequently than are injuries to the medial deltoid ligament. Swelling, ecchymosis, or tenderness, if detected earlier in the examination, will make the examiner aware of the possibility of a lateral ligament complex injury. The examiner must try to assess the degree of injury and determine if any instability of the ankle joint is present. In a complete tear of the anterior talofibular ligament, the restraint preventing forward sliding of the talus in the ankle mortis is lost. With the patient sitting on the examining table, the hind foot is grasped by the examiner's cupped hand, while the opposite hand grasps the lower end of the tibia just above the malleoli. Anterior pull of the hind foot is applied at the same time as posterior push on the lower tibia. Excessive anterior motion of the hind foot as compared to the opposite extremity denotes anterior instability. The examiner may appreciate a clunk as the talus subluxes forward out of the ankle mortis. The anterior drawer test may not be diagnostic if the pain of the acute injury prevents full patient relaxation and cooperation. Local or general anesthesia may have to be utilized in order to perform instability tests accurately. For lateral instability, both the anterior talofibular ligament and the calcaneofibular ligament must be torn. This injury will allow the talus to tilt in the ankle mortis. When testing for lateral instability, the ankle should be allowed to plantar flex to approximately 30 degrees. The junction of the mid and hind foot are grasped in the examiner's hand and an inversion stress applied. Carefully palpating laterally, the examiner may appreciate gaping of the lateral soft tissues as well as tilting of the talus. Since talar tilt may be found in the normal subject without a previous injury to the ankle, it is absolutely essential to compare the opposite normal extremity. The examiner must be certain that the increased inversion is occurring because of talar tilt and not because of subtalar instability. Both the anterior drawer test and the talar tilt test should be confirmed radiologically if thought to be present clinically. To test medial instability, which is much less common, the examiner applies a knee version stress to the junction of the mid and hind foot and carefully palpates the medial aspect of the ankle joint for gaping or widening. Achilles tendon rupture. With any injury involving the lower leg, the integrity of the Achilles tendon must be ascertained. Approximately 25% of Achilles tendon ruptures are missed because of failure to adequately examine for continuity of the Achilles tendon. In order to test the integrity of the Achilles tendon, the patient may be examined in any of the following three positions: kneeling on a chair, lying prone with the feet suspended over the end of the examining table, or lying prone with the knees flexed to 90 degrees. In either of these three positions, squeezing the calf will cause plantar flexion of the foot if the Achilles tendon is intact. Failure of the foot to plantar flex signifies a rupture of the Achilles tendon. Gastrocnemius soleus contractor. If during the examination the range of ankle dorsiflexion is decreased, the examiner must try and ascertain the reason. Structural abnormalities about the ankle joint may prevent dorsiflexion, but also contracture of the gastrocnemius or the soleus muscles can limit dorsiflexion. With the knee extended, passive dorsiflexion of the ankle may be limited by the gastrocnemius and or the soleus muscle. If the knee is then flexed, the gastrocnemius muscle, since it originates above the knee, is relaxed, and a failure to gain passive dorsiflexion would implicate the soleus muscle as being the cause. Conversely, if dorsiflexion is achieved with the knee bent, but not with the knee straight, then a contracture of the gastrocnemius muscle is the cause. Hohmann's sign. Hohmann's sign is a test for deep vein thrombophlebitis. The patient lies supine with the leg extended and the foot and ankle are forcibly dorsiflexed. Pain elicited in the calf region in response to this test indicates a positive Hohmann's sign. This sign is certainly not pathognomonic and must be correlated with other physical findings suggestive of deep vein thrombosis. In summary, the foot and ankle region have been examined in detail. You are reminded, however, that the examination of the foot and ankle is not complete without the corresponding examination of the lumbar spine, hip, and knee.